guys, I'm back with another video. So today I'm here to fill you guys in on my clinical experience. So I have had 2 clinical days thus far on Sundays for SURG. We're on the Tele Unit and it has been quite interesting. My first clinical day, I was in my mind like, please do not give me a patient that needs a catheter. I am not ready for this. I haven't done one since LPN school and it was only on a woman. And I also was like, please don't allow my patient to have a PICC line. Please just not give me that the first day, right? 6 a.m. gets here, get on the floor at 6 a.m., get all my things, get my report from the nurse on my patients. And of course, guess what? My patient had a PICC line. And guess what? I went, assessed my patient, questioned him about, the GI system, GU system. And I was like, when was the last time that you urinated? Because he was using a condom cap. And the bag didn't even have 30 mLs in it. And he was like, yesterday. And I was like, oh, what time yesterday? And he was like, I really haven't been going. I mean, I think it was like afternoon. Okay. So I go communicate with his primary nurse, of course, because I'm just a student nurse. I'm in the student nurse role. And she checks his chart, and on his I's and O's, it said that he had 200 mLs at 1 a.m. And every 8 hours, a patient should at least be producing 240 mLs. It's like, okay. She was like, well, that's not too bad. Let him eat breakfast and everything and see if he needs to go. Because when I assessed him, his abdomen was distended, like a lot. And it was tender when I palpated it. But he said he wasn't feeling any pain unless, when I palpated. And so he was like, I feel like I need to go, but I just can't go. So he was assisted to stand because he said, I feel like if I could stand, I can urinate, because he was admitted in the hospital for necrotizing pneumonia. He was a pre-COVID patient. Post-ox wouldn't get above 85 with 6 liters of oxygen. So he was on strict bed rest. They did not want him ambulating, but we did do that just to see. So when he stood, he only put out like 600 mLs. And I'm only saying only because prior to that, I was like, I'm going to do your bladder scan just to see how much urine is in there. Did the bladder scan, and the screen went to the maximum. It said over 1,000 mLs. That's a lot, because when you reach about 540 mLs in your urine, it starts hurting, because it's like you're holding your bladder, so you start feeling like abdominal cramps and stuff. But he wasn't having that. So he stood, put out about 600 mLs. So I was like, well, okay, you still have some in there. So I went communicate with my preceptor, and we did another bladder scan. The bladder scan still said like 800 plus mLs. Okay, so I had to call the doctor, and the doctor wanted him to get a Foley catheter because of him not urinating. So we did that, and as soon as I inserted the catheter, we got like 700 mLs of urine, like just filled the Foley bag. And he said he felt so much lighter. He was relieved. Like, he was very anxious with getting this catheter. I wasn't anxious because I guess I've been in nursing school before, and I wasn't nervous about putting the catheter in, but I was like, man, this is like my first male patient, like my first male person that I'm actually giving a catheter to. I have never done that before. So it was quite the experience, just providing therapeutic communication for him, because he had never had a catheter before, and it was very successful. It was relieved, and of course it didn't feel great, but he said it didn't hurt as much as he expected. Sorry y'all, I'm kind of like sweating. So that was that clinical experience that day. that was pretty interesting for me that I wanted to share with you guys. I didn't do med pass that day, but I did do charting because the system was kind of like to log in, so my preceptor allowed us to use like something else. And second clinical day on the Tele Unit, I was assigned 2 patients. One of my patients was in there for emergency hypertension, and then my other patient was in there for a left femoral pop, so she had to have surgery. And also, the coolest thing about that day is I got to see a thoracentesis when they go in and drain the lining of the lungs. And I mean, it was quite the experience to see that. I've only seen like YouTube videos on it, but like seeing it in person was like a different aspect. Like I didn't realize that the needle goes as far as it goes, you know. And it is uncomfortable for the patient. It's not a good feeling. So you have to keep talking to them, give them support, and providing therapeutic communication with them throughout the whole process. But quite interesting to see. Y'all might want to Google a thoracentesis on YouTube if you know what I'm talking about, or if you're just interested in seeing one done in case you don't get to see it in your clinical rotation while in nursing school. So I wanted to share that with you guys, and I'm so excited. I go to NICU Monday, and I go to a pediatric clinic on, not NICU Monday, I have class Monday, I have my OB test Monday. I go to NICU on this coming Tuesday, and I'm so excited about going to the pediatric clinic as well. So I will definitely be giving you guys a lot of insight on those things. So this is my part 2 of my clinical experience on the med-surg unit. So like I have stated before, I go to the NICU on this Tuesday that's coming up. So yesterday I had clinicals on the Tele Unit, and I had one patient that had acute kidney injury, and my other patient had a cholecystectomy. So they had removal of the gallbladder. She had, her incision was lateral across her abdomen, and it was held in place by steri strips. So the biggest thing yesterday for her was getting her to ambulate and making sure that her blood pressure was decreasing, and that she was just moving around to prevent DVTs prior to her having her surgery. Also, I got to do my first IV push for her. It was a great experience. I've never did IV push before. I always have the experience of hanging piggybacks being an LPN, but as you know, LPNs cannot do IV push. But now, since I'm an RN student, I got that experience, so I push morphine. And so when you're pushing morphine, you have to push it over at least, 2 to 5 minutes, and you have to make sure that you dilute it prior to giving it, because if you don't, pushing that morphine, it will just give that patient a fast high. Their respirations could decrease very quickly, and it cannot be a good thing. So that was very interesting. Also DC'd her catheter, so that was pretty cool. I hadn't done one of those in a while. And yeah, I had a great experience. My patient with acute kidney injury, she only had one functioning kidney, and she was in there because her blood pressure had been very, very high. It was like 201/81, and the trend was just going up and up and up. So before she can get sent home, her blood pressure needed to be under control, because of course everything affects our kidneys. Our heart affects our kidneys, our liver, and everything. So we had to get that settled. But I just wanted to give y'all a little quick update with that, and I cannot wait to show y'all my experience. Well, inform you guys of my experience in the NICU on Tuesday. So thanks for checking out this video. Like, comment, or subscribe, just anything. Like, if y'all have any recommendations or any videos that y'all are interested in seeing, just comment below.